Hello, Dr. Rahul Mahadar here. Today I'm going to discuss about a large incisional hernia which has been treated with eTEP repair. 72-year-old female patient with history of diabetic hypertension and ischemic heart disease has been taking antiplatelet medication for past decade. She presents with a chronic non-healing ulcers on both feet due to bilateral diabetic foot. Additionally, she has been suffering from chronic kidney disease for past 5 years, but has not sought consultation with nephrologists. In 2019, she underwent exploratory laparotomy with panhysterectomy for large fibroid uterus at another facility, during which bilateral ureteric catheters were inserted. Since then, she has developed chronic kidney disease and she was referred to our facility for large incisional hernia that is incarcerated and irreducible, causing continuous abdominal pain. This is her clinical picture in office visit. These are CT scan abdomen picture, which is suggestive of large incisional hernia with bowel loop incarcerated, and because of which she was having continuous pain in abdomen. After consulting with nephrologists, the patient's fitness for surgery was assessed and pre-optimization with drugs were recommended. Bilateral color Doppler imaging of both limbs showed normal results. The cardiologist performed angiography and determined that the patient had diabetic cardiomyopathy with ejection fraction of just 30% with no major blockages observed. Patient's BMI was 29.4 and HbA1c was 6. Patient's antiplatelet medication was stopped for 5 days in preparation for the surgery, and now she's ready for the operation. We planned for eTEP RS SOS limited TAR, unilateral or bilateral according to the situation. But here in this case, we performed eTEP RS with complete sac preservation. Enjoy the video. After precostal entry on the left side, we directly enter into by open technique into a left retrorectus space. The telescopic dissection is done with 10 mm 0° telescope. And after doing this dissection along the lateral border of the rectus, we put a 5 mm trocar, and then with the help of a ligature we are dissecting the left retrorectus space towards the symphysis pubis, that is space of radius. Here one can use the other energy sources like monopolar current with monopolar current or ligature. So I am dissecting towards this symphysis pubis. You can appreciate the inferior epigastric vessels on the roof and going into the plane between two layers of transversalis fascia. So now the third trocar, again 11 mm trocar at the lateral border of the rectus, and then the optics is shifted to this trocar and midline crossover is accomplished with cutting of the posterior rectus sheath 0.5 mm below the linea alba. While doing so, I am extending this incision down, and while doing so, I accidentally open the peritoneum at the level of the hernia. You can very well see here, and because of that, the space is obliterated, but still I can continue with the midline crossover. The falciform is quite large in this patient, so I could able to take down the falciform. And now you can appreciate the linea white structure and pinkish structure just lateral to linea, and that is where I'm taking the incision on the opposite side posterior rectus sheath on the right side. So there you can see the muscles after taking incision over the posterior rectus sheath, and now this incision is craniocaudally extended uh, so that I'll complete this midline crossover. Still that optics is in a third trocar, and I'm extending this incision and doing the dissection because I'm using here 10 mm 30° telescope. Now the optics is shifted to first trocar, and with these two hand instrument into other two trocars, I have now started dissecting in the midline and approaching towards this hernia. And here you can appreciate the hernia sac, which is quite big. Hernia defect is quite big, and the peritoneum is very thinned out. So I have to open it. So after opening, I can see the adhesions inside, and the suture material is going through this omentum, omentum and bowel loop. So that is cut, and this adhesiolysis is done with cold scissors, as there is no bowel here, only omental adhesions are there. So that is still taken care of with the help of a cold scissors first. Now here I am 100% sure there is no bowel, so I am using current to achieve the hemostasis. So with the help of a ligature now, rest of the adhesions are cut. Along with the defect in the inferior abdominal wall, there is a loss of peritoneum as well in the lower part. So still I want to purchase the peritoneum and posterior rectus sheath, so that without doing transverse abdominis release, whether I can close the posterior rectus sheath, that I want to try. And for that I have taken incision here along the medial border of the rectus on the right side, and I will try to preserve the sac, and with that I will try to close the peritoneum PRS complex. So now for preserving the sac, I started dissecting the sac. There is quite a thick sac was there with good vascularity. Assistant is asked to give pressure from outside, and the dissection of the sac is carried out. This will again prevent the seroma formation in the postoperative period. This sac was quite thick, and with the help of a hook, we are getting into the plane so that only sac is pulled inside. So all the finer attachments of the sac that are freed from all the sides. And then the connection of the sac with the posterior rectus sheath on right as well as left side is maintained so that the blood supply of the sac will remain from one end. Traction and counter traction is the key for getting into the planes of at the previous operated site. Now here you can see the complete the connection between the sac can be achieved now. Getting down into the plane is difficult here just because of the previous scar. And I'm going down as far as possible. The entire operation is done with only 3 ports. And now I'm going to connect both the sides. As this is almost below the arcuate line, so here we have to go only preperitoneal. So here I'm connecting this and send preperitoneal. On both the sides simultaneously I'm doing the dissection so that I don't miss the plane where I can get this sac also attached, and going into preperitoneal plane. So here is a scar tissue. That scar we have to cut the scar and then get down into preperitoneal plane. So now Bogro space is dissected. Now here you can appreciate the inferior epigastrics on the right side. And into space of red GS. So now after completing the dissection, now I'm measuring the sac that can cover the defect in PRS peritoneum complex. And there is no need of doing further dissection now. So we'll start doing the linea alba reconstruction. And to hold this particular defect, it is which is around more than 6 centimeters is 6.4 centimeters. So for that, I'm putting a transfacial sutures with ethylene and asking the assistant to hold it from outside. So after tightening that, you will see the midline closure becomes quite easy. So now I am using 1 number Statafix for closure and reconstruction of linea alba. So entire reconstruction of linea alba is done from GP sternum to almost symphysis pubis here in this case. So after complete reconstruction, below the umbilicus, then I started the reconstruction from GP sternum down towards the umbilicus, and that is also done with Statafix 1 number. And now, and then I started the PRS reconstruction. Here I am utilizing this sac, so I am taking actually 4 to 5 stay sutures all around, and then with the help of a 2-0 V-lock absorbable, the entire edges that are sutured So now, after reconstruction of PRS, we just see whether it is completed or not, and then the measurement of the dissection part is done with the help of a umbilical tape, pre-marked umbilical tape. Now polypropylene macroporous 30 by 20 centimeter mesh is put and fixed with the help of a glue. Thanks for watching.